I'd like to give you some background information on Dr. Heng, our next speaker. He is a graduate of the University of Illinois College of Dentistry and the University of Minnesota Orthodontic Program, where he briefly taught orthodontics. He then established a very traditional orthodontic practice in rural Vermont. After about 7 years, he became dissatisfied with the faces of the traditional orthodontic approach, produced and embarked on a continuing education journey that ultimately took him to 50 states and 30 foreign countries. In the process, he moved to Southern California and developed a truly unique orthodontic practice with strong emphasis on facial aesthetics achieved with innovative early treatment and adult treatment, but also became aware of the significant positive effect some of his treatments were having on the airway. This opened up a whole new aspect of orthodontics, maximizing the airway for all orthodontic patients and specifically treating patients with sleep-distorted breathing or obstructive sleep apnea. Having been reopening previous extraction spaces since 1989, Dr. Heng recognized a syndrome he named extraction retraction regret syndrome. His approach to orthodontics is a result of blending the best ideas from the best practitioners and adding his own unique experiences. He has spoken on orthodontics, facial aesthetics, and airway locally, nationally, and internationally, and appeared on the British equivalent of 60 Minutes. He was the founding president of the North American Association of Facial Orthotropics, is a board member of the American Association of Physiological Medicine and Dentistry, and is an advisor to the Academy of Orofacial Myofunctional Therapy. Please give a warm Academy welcome to Dr. Heng.
Thank you. Thank you. The title of my talk really isn't coming from me, but you're going to see the person who gave me the idea later on. Because I do think excuse me, I want to show you that. That was good. Got to show that. See, I'm not very good tech. I don't even have a cell phone, but I was able to do that. So, just so you know. And I don't know if that's true or not, but the fact is, let's look at how far forward does the face really have to be to live and prosper. I could give you a zillion references, but this is a good one from Harvard, an anthropologist who said, look at here, you know, our faces aren't as far forward as they used to be, and that's the issue. That's why we're here. It's all about in the anterior posterior plane of space, basically. And we accept kids who look like this. They look, that Bolton norm, the black line, this girl's really right on it, which is pretty good, very attractive face, but over time as she matures from about age 8 to 13 or so, you see how her face falls back, and she looks like the rest of us, and your kids and my kids and everybody, because we're all back. The maxilla, the mandible, most of us. This is really interesting to see people say there's malocclusion is genetically determined, and yet no one ever has any evidence to support that. I believe that it's mostly environmentally determined. So here you see something that really never happens, but it did. Two kids that are adopted separately, and you see them grow up. And this was on a national television show where these two people came together. Now you look at her now, the one on the right looks pretty balanced face, and the one on the left, by the time she's a teenager, she has a long face, she's in braces, and it looks like her maxilla is ready to fall out of her head. She has horrible rest oral posture, and her face height is getting long. And the point here is that she is not attractive and getting less attractive every day, and yet their DNA is exactly the same. And here you see them come together later on. Here they are in college, you see the pictures. They are identical twins. And here they are on this television show, Dr. Gupta, or whatever it is on whatever, I don't even know where it came from, but they're the same. They are genetically the same. But the one on the left there with the long face, she's going to be the one that's going to be the train wreck. And she's the one in braces, and she's been in braces more than once. But look at her maxilla, how far down and back it is. Here's one of my own patients who literally, his mother would not do any myofunctional therapy. He even said to me one day, if you send me back to that Barbara Green, I'm going to leave your practice. She said that in my waiting room with other mothers sitting there. And so her reward was to have her son's face fall down and back, and ultimately when he's 15, have an x-ray taken like this, and then be diagnosed with sleep apnea at age 15. So what are you going to do at age 15? CPAP machine for the rest of your life? Good luck with that. Good luck with that. So And we now know that OSA is associated with all the chronic diseases that known to man. This is a little diagram from John Mew, and he has a proposed Paleolithic profile of an 18-year-old person. In orthodontics, we have various cephalometric analysis, and this is one called the Steiner norm, and that's where the maxilla would be with the Steiner norm. McNamara, who's still practicing in Michigan, has his norm. That's where his norm would be. That's where the maxilla would be. And yet, our ancestors would have been, courtesy of John Mew, he thinks they'd be this far forward. Our ancestors didn't have sleep apnea, or we wouldn't be here. They'd have died out as a species. Joy used to talk about this years ago, and I used to think you were crazy when you were talking about we're going to die out as a species. And now I'm thinking, darn, you're right. And I'm worried. And that's what this is all about. How far forward do you have the face? And sadly, the faces continue to fall back if we don't have proper restoral posture. That's why I depend upon Joy. And she showed half my practice this morning, all these patients, we work together all the time. Couldn't work without her. The sooner we correct the problem, the better it's going to be. And the most important thing is not to do anything that's going to make the problem worse. I love this picture because it's taken by Jen Salzer in New York, who took my mini residency, and that's her son Mason. There she is driving in New York with her, taking a picture of her son with a cell phone in the rearview mirror with his mouth open. And her goal in taking my mini residency was to help him learn to keep his lips together. So she brought him out 1 year for me to do the adjustments on the appliance, and here they are flying back to JFK. Now, notice her husband with his face back, mouth hanging open, snoring, and yes, he has sleep apnea. And there's Mason with his nicely positioned face, and just a random person in the window seat. Probably sleep apnea too, right? Now, look at, this is great. On Long Island at camp the next summer, there's Mason with his lips together, and all the other kids have their mouths hanging open, just like your kids and grandkids and all the other kids in school who are going to have long faces and all these issues. But she keeps me updated. Before Thanksgiving several years ago, she sent me this and an email 2 days before Thanksgiving and showed these pictures. There's Mason, and there's his father with a long face as a teenager. Later on, this one I love. I guess I'll be sending you pictures for the rest of my life. Still can't believe we got this profile from where he started. Thank you, thank you. The very next line was, oh, by the way, the other kid is not mine. So, but the other kid is what we're used to. This is becoming the norm, just like weighing 250 to 350 pounds is becoming the norm. So I got really excited about all this stuff years and years ago, about the year 2000, when I was recognizing this orthotropics craziness I've been doing all these years actually improved the airway. And we did a study on this, and we saw that it improved at 31% at the dorsum of the palate, 23% at the angle of the mandible, and way down the laryngopharynx, even 9%. And that was on a bunch of my treated patients that I kept records on. And you can notice this is a class 2 patient, and we actually advanced the maxilla in the class 2. Every class 2 has a maxilla that's too far back. But what do we do in orthodontics? We shove it further back. And we've known, July of 1981, we've known that the maxilla is not too far forward. If it's not ideally positioned, it's usually too far back. And yet we still do the headgear thing. So this is kind of embarrassing here. This is a patient who came to me and had 4 bicuspids enucleated at just short of age 10. They were taken out. And I didn't reopen the extraction spaces, and you can see what happened to him. Somebody else took the teeth out. But so look at his face. The maxilla collapsed. But the real deal here is look at the distance between the chin and the neck. That's the problem. And what's going on, if the more the chin goes back, the more the tongue goes back, the more the airway closes down, just like Michael talked about and just like Joy has talked about. And then I like to use this. I'd love to see everyone have a garden hose for an airway. But now with cone beam, we realize that a lot of people have a drinking straw airway, and some even have a cocktail straw airway. Those are the people that are not going to live long. They're not going to be around to collect Social Security if Social Security is still around when they're around anyway. So Let's talk about facial aesthetics and how do we diagnose it here. And this is a commonly used thing in orthodontics, which, to be honest with you, should never be used. But it's been in the profession since the 1940s. And so here you can see, apply it to these two people, the mother and the daughter. The mother who's had 4 teeth taken out and has a caved-in face, and her daughter where we didn't take out teeth. Who looks better? The mother has a coffee grinder sounds in her jaw joints too. As no surprise, Michael knows all about that. That's what he does for a living, to treat those poor people. And now it's embarrassing when I look and show you one of my own cases, one of the last people in the early 1980s when I took 4 teeth out for this kid, when I used to take out teeth all the time before I quit doing that. And here he came back with his own kid. On the right-hand side, you see what he looked like as an adult, bringing his child to me for orthodontics. How do I feel, having dished in his face? This, of course, was before I even realized that people had to sleep and breathe. So if I didn't realize what I'd really done to him. So the next thing you need to know is the facial contour angle. Okay, it's pretty simple. Straight line from the forehead down to subnasale and then the chin. Minus 11 degrees with plus or minus 4 degrees on that for standard deviation. So now let's apply this to 2 racial groups. Let's look at an African American woman here from Milwaukee that I have reopened 4 extraction spaces for. Look how her lips are full. And look how the Asian girl here is full. That's called bimaxillary protrusion. We hadn't yet discovered that people only have 1 maxilla, so we called it bimaxillary protrusion. Now, when they discovered that they have only 1 maxilla, we call it bialveolar protrusion. But in reality, it's not protrusion at all. This is like trying to change the spots on the Dalmatian. You might want to leave them there. That's what they're supposed to be. But let's look here how it gets so misdiagnosed. In this case, the African-American woman has her chin back a whole standard deviation. The Asian girl has her chin right on the money. But the real problem is African-Americans and Asians have shorter noses than Caucasians. So of course their lips are going to be full. I saw a recent statistic that said 75% of kids in Asia that are getting orthodontics are having teeth taken out. That's a great way to get rid of a population really fast. Take out the 4 teeth, pull them back, get rid of their airways. I mean, I get people all the time. I had a woman from China contact me 2 weeks ago wanting to have her spaces reopened. I get them all the time, and they're at great risk. Here we go. See, would you take out teeth for a girl like that just to make her teeth straight? The teeth are in perfect harmony with the tongue and the lips and the cheeks. Why are you going to change that? And risk this, which is the bottom line. Reducing the airway. That's from China. And this is from also from China. So you know this can happen. This can happen. By the way, we had the airway conference in Marco Island, Florida 2 years ago in January. American Association of Orthodontists was exploring the relationship between sleep apnea and orthodontics, and they determined there was no way to cause it. But for whatever reason, they didn't have a 10-year-old kid to get on the cell phone who could have found these articles on the internet. So what do? The orthotropics is the diametric opposite of traditional orthodontics. We take a little girl like this, and what we have to do is to say, forget about the teeth. Let's talk about the face. What are we going to do? We're going to do the completely sacrilegious thing of pushing the upper front teeth forward. Look what we just did here. Are you freaking out? I pushed the teeth out there. Are we going to push them off the bone support? Do you think that? Were you taught that? If you were taught that, the person teaching you that has ignored 7 articles in the refereed literature that says it won't happen. Now we bring the mandible forward without a headgear effect. Are you worried about recession? She's no longer tired all the time. She's 2 grades ahead in schoolwork. And her parents flew her to see me from Seattle to have this treatment. And so her mother went nuts when I showed her the airway improvement from 13.1 to 186.1. And notice the profile improvement. But you're only going to get this when you advance the teeth. Yes, can we expand laterally? Yeah, that's fine. But the problem is in the anteroposterior plane of space. And unless and until we develop the face forward, we're going to fail. That's what this morning is all about. There she looks. She's on the cover of, they take her all over the place. She rides her horse here, there, and everywhere. And that's what she looks like. What about this? Daughter of 2 dentists in a town in the Central Valley of California, about 4 hours from us. She's had sleep apnea as a kid, already diagnosed with it, had primary teeth taken out, had someone line these teeth up, an orthodontist friend, and now ready to have the 4 bicuspid teeth enucleated, extracted before they erupt. God forbid we should allow teeth to come into crowded positions. But in her case, would they come in at all? No, they'd never come in, would they? So, now, what are we going to do? We put an appliance in the upper to expand and advance the upper anterior teeth. Now notice that the teeth overlapped in the front, correct? And we're going to advance the lower front teeth with a removable appliance. Now hold on to your hats here. Has everyone got your seatbelt fastened? Okay, now here she is in the midst of the treatment. Do you like that? How many orthodontists are here? Any orthodontists? They teach you to do this in training, where you purposely create an anterior open bite. No, they didn't. Frankly, if they showed this picture that you'd done this, they'd probably want to take your license away. Okay, please notice that I have gone from no open bite to a massive anterior open bite. But through the magic and wisdom of John Mew, we intrude the upper first molars using the primary second molars as anchorage. We push those first molars up just like the surgeon would do in a Lefort 1 maxillary osteotomy. We elevate the entire maxilla up. Then we wipe out the teeth, the primary teeth get wiped out, and the bite closes. But you think, oh my gosh, wait a minute, we got to show you this. Got to go back, sorry. Here the teeth start to come together on their own with the appliance systems that we're making for her to learn to keep her lips together and become a nasal breather. Notice the cuspid teeth, which were 100% crowded, have come in on their own. And look at the teeth that came together without any treatment by me at all. That massive open bite closed on its own, and orthodontists would say, but this can't possibly be stable. Well, 2 years later, with no appliances, no extraction of permanent teeth, and no traditional braces, that's what she gets, and she's never worn braces. And her retainers are her tongue and her lips and her cheeks. But the real killer thing here to learn is the airway improvement that you see. That's that cross section is post-orthotropics. That airway on this little Asian girl is bigger than probably any airway in this room. Definitely bigger than mine. If I had that airway, I guarantee you the Kenyans would fear me at the Boston Marathon. Those guys that see me, oh no, it's Hang. Well, we're not going to run today. We know he's got it in the bag if he had that airway. By the way, I've been taping my mouth for 10 years, and I have 2 years, knock on wood, not a cold. No cold, 2 whole years. Used to get at least 2 a year. Lips together. So there she is. Do you think it's okay that she has a slightly full face? But that's her heritage. That's what she should be. Why would we want to flatten her face? Just because we have a stupid norm we use in orthodontics that isn't even appropriate for using on Caucasians. Why would we use it on another racial group? So it took me a long time. I'm a slow learner, and I was doing this orthotropics thing at the age 8 and 9. But I began to look and say the patients that I was waiting for those teeth to come in on, their faces were falling down and back. So why wouldn't I treat them right away? So for those of you who are in the AACP, like Stacy Cole and Mike Balin and Michael Gelb and any others that are here I might have missed that know this, you look at this little girl with a deep bite like that, retroclined upper incisors, gummy smile. You know this girl's an accident looking for a place to happen. That's what it is, an accident looking for a place to happen. She's going to be a TMJ candidate. Why would you sit on this and when you smell the smoke and for 3 or 4 years, or even more than that, wait for all of her teeth to come in, wait till she's 13 and put braces on her when the smoke is there? And would you call the fire department? So let's do something about it. She's got long roots on her primary teeth. They're right there. And you wouldn't do this if you were older and she was losing the roots of those teeth. But look at this, what did we do? I pushed the upper anterior teeth out, splayed them out like crazy, created an overjet where there was none. Then we brought her mandible forward with an appliance that negates the headgear effect. And here she is later on. If I were to treat her again, I would have expanded her mandible in the primary dentation. I didn't have enough guts to do that 14 years ago when I was treating this girl. She wouldn't have that crowding that she has in the lower. She wouldn't have needed a phase 2 treatment. I learned from my own mistakes, thankfully. There she is, just taken earlier this year. She's applying to colleges. It's fun to see a kid who's, tiny little kid, and now she's ready to graduate high school. And her face goes from being recessed some to being perfectly forward like that with the treatment. And imagine, I don't take x-rays to prove this on what happens to the airway because I just frankly can't justify the radiation anymore. But when the parent tells you all the positive things that happen, then you're happy. Now, I happen to have been at this orthodontic game soon to be 49 years, and I know darn well that that little girl on the left-hand side is not going to turn into the little girl on the right-hand side without some change. So why wouldn't we treat? I've got 14-year-long records on her. Gummy smile, gummy smile. How about this one? If you think the previous one was going to have a bite problem and an airway problem, when you see this, the mandible is essentially trapped. It's not going to grow forward at all. The upper anterior teeth, it's almost like a roadblock for mandibular growth. And when she smiled, all you see is gum tissue above the incisors. That's what this smile is. That's a bit of a deep bite, isn't it? So, does anyone have the intestinal fortitude to go in and push these teeth forward like crazy, like that, on the previous one? Look at her face. She's back. And so what do? We expand laterally, but more than that, we must advance the teeth, 8 to 10 millimeters. We advance the teeth and make her look, frankly, just a bit freaky. Now, as a mother, would any of you be concerned right now? Oh, come on, be honest with me. You'd all be concerned, wouldn't you? And what do I do in the practice? I look at them and say, Mrs. Jones, we're pushing the teeth out just like we told you in the consultation, but if by next time you don't think I'm stark raving crazy, I'm going to say you're an unobservant mother. They come back, I've warned them this, Dr. Hang, her teeth sticking out. Yeah, I noticed that. That's great, isn't it? So we're able, and here's another case, learning I would have expanded her mandible. Look at the crowding that I didn't take care of because I didn't have the intestinal fortitude to expand the mandible prior to the eruption of the 6-year molars. Now, most of us learned in orthodontic training that you can't even expand the mandible at all, certainly not in a kid or an adult. You're going to push the teeth off the bone support. Did you know there's no suture in the midline of the mandible? Were you taught that? Yeah, I was too. But that doesn't mean you can't expand the mandible. I expand adult mandibles 8 or 9 millimeters often without any surgery, and I don't push the teeth off the bone support. I've expanded my own maxilla and mandible 7 millimeters. I did that 31 years ago. Certain people will say you can't expand the adult maxilla without surgery. I'm really happy that my maxilla is illiterate and it doesn't read those articles because my maxilla was able to be expanded. So here you see this mandible coming forward looking like that. And by the way, this is one of 3 children I've treated in the primary dentition. I'm currently treating their youngest brother. And the most motivated mother in the world is the mother who's had 4 teeth taken out, suffering chronic pain and breathing problems. And I've reopened her extraction spaces, and she's willing to drive her little children all the way from San Diego suburb to my office north of Los Angeles for this treatment, past about 5 million orthodontists along the freeway. So, I've shown you treating in the primary dentition. Now, there's a group of us who meet and have been on COVID ever since last March and April. Susan Maples is here, Kevin Boyd. There's a bunch of crazy people on a phone call every Monday night because our goal in life is to make what I just showed you, the standard of care and help these kids long before they have the brain damage that we know they're going to have. In Nashville, I showed you quotes from Ron Harper, from neurobiologist at UCLA, showing how brain damage occurs with just one night of reduced oxygen saturation. So will it cure everything? Well, let's look at that. Let's look at this kid who's an autistic little boy. He's on a CPAP with a mother who is a very knowledgeable pediatrician who has sleep apnea. And is she focused? You bet. So we're going to treat him in the primary dentition. We push the teeth forward. Look how full his face is now. Now, here he is 2 years later. I've finished it, and he's hard as heck to treat. Believe me, he was very challenging to treat. Here he is forward. And let's look at his face with what I did with him. Look how full his face is right now. The normal angle for a nose-lip angle would be 90 to 110 degrees, with 100 being ideal. He's at 91. This is a very full face. And if we look at him, you see the mandible. Look at where the mandible is. The mandible was back behind this line at 13 degrees. Now it's on a straight line. His mandible is farther forward than almost all kids today. Okay? We put the Bolton norm on his face, and you can see that the lips are really right on it. We don't see kids in our practice who are even close to this. But when you have a mother who's all over the kid like crazy to make him wear the appliances, and we've blown his teeth forward, you can get this result. But that wasn't enough for her. She left the area for many reasons, moved up north, and is being treated by a dear friend of mine who's my student, Brian Hockel. And he's a general dentist in Walnut Creek who does the same thing here. And she insisted that he do it again. Notice that he had low rest tongue posture and all. Now, after Brian has done this, look how full his face is. You won't see a face with a nasolabial angle like that very frequently. And there he is from the side. You see how full his face is. And you see, still on the Bolton norm, pretty close to that. This hardly exists in society. Unless he'd done orthotropics like this, his face would be down and back like everybody else because he's a chronic mouth breather. The fact of the matter is, he still had sleep apnea. He had a sleep study done at Stanford. With that face, he still had low rest tongue posture. He still has sleep apnea and is on a CPAP machine. This is his mother. Her face is back, like all. And he goes, I sent her to Larry Walford, who brought both jaws forward, and this is what she said to him. I don't care if I look like a gorilla. And this is where the title of my presentation came from this woman. Because she says, I think we're going to need to look like gorillas. And I think maybe she's right. Here's after her surgery to bring both jaws forward. She had an acute nasolabial angle after, and now it's really acute. And her mandible is way forward. It started back at -5 degrees, which is further forward than most people, and yet she had apnea. Here she is, literally 10 degrees forward, and I'm not sure she's out of the apnea yet. So it's kind of crazy, isn't it? It gets a little scary when you think you do your best and you don't always knock it out of the park and get a home run in the upper deck with the bases loaded. I've been reopening extraction spaces for people since 1989, and I've learned a lot in doing that over the years. And I've had people from more than half the states come to see me in several foreign countries. But we don't confine opening spaces to someone who's had teeth taken out. Now you're going to see something that if you choose to do it, make sure that they never go for a second opinion. Because if you do that, you may end up in peer review, and you may not have a dental license afterwards when they're going to tell you that what you did is not the standard of care. She is a train wreck. She's never had ortho, but Michael Gelb would go through all his thing and see everything is bad. Every muscle north of the navel's on fire. So what are you going to do? She doesn't have sleep apnea, but she has plenty of overlap of the teeth in the front. Her upper incisors are very vertical. These are the patients where you expect them to have the pain pattern. And when they don't, you're kind of happy, but expect it. So here, what are we going to do? We're going to put in 4 extra bicuspid teeth. Now, that brings you to thinking, oh my God, this Hang guy is pretty a nutcase, isn't he? but her pain pattern is gone. And I'd like you to look very carefully. Do you think she's going to lose her teeth because we've pushed them forward? She's going to lose them to gum disease, to recession. By the way, do you people? I used to when I read the newspaper. I don't anymore because it's too sad. But I used to read the obituary columns. Did anyone do that? It's kind of fun. I like to do it because here's a guy. He's 88 years old. He born in Kansas, went into World War II, served in the Pacific, and then he somehow came to Southern California. He didn't go back to the farm in Kansas. Can you imagine? He liked the sun in Southern California. Then he died, and I read the whole obituary. Cause of death, whatever. Do you ever see anyone that was, they sometimes list the cause of death. Did you ever seen anyone die of gum recession? It's pretty safe that is not a cause of death. Look up the statistics on sleep apnea related to every chronic disease. So here we are. We got the implants placed. Look at that, ready for the implants. And now we put in crowns. So she's got 4 extra bicuspid teeth. Please look carefully to see if you think she's going to lose her teeth to gum recession. This woman is super happy. Her pain pattern is completely gone. And oh, by the way, look at that maxilla, how wide it is. Look at that maxilla on the left and look at it on the right. Did I do something good for her, or should I have my license taken away because I'm practicing not the standard of care? You decide. And which smile would you rather have? The narrow one that looks like she got caught in an elevator door, or the broad one? The best smile ever that I want to rely on talking about all the time is Tiger Woods. He's got these big, huge teeth, broad smile. I don't think he's smiling now, but he's back in the news, and I refer to him as having a great smile. But it's because it's so broad. He's not going to be the guy with sleep apnea. Look how far forward her lips came when we did this for her, just by doing this craziness of pushing her teeth forward. So let's look at some other interesting cases here. How about a woman who has an upper left bicuspid taken out to make her have class 1 cuspids, because you know you have to have cuspid guidance. You learned that, didn't you? You learned about incisal guidance too. But you never knew Brendan Stack, who practiced in Virginia, and one of the things he passed away. He's a founding member of the American Academy of Craniofacial Pain, one of the brightest guys I ever met, one of my mentors. And speaking in 2011, he said, one of the worst things ever foisted on the dental profession was incisal and cuspid guidance. Now, I know I just stepped on a whole lot of toes right now, but here I am, frankly. I know I'm going to get a hug from my patient when I'm reopening the extraction spaces and suddenly I produce an overjet. It's like the sun coming up in the east. Oh my God, Dr. Heng, I feel great. I feel great. Now, am I supposed to listen to these people and say, oh, you're all nuts? No, you're making that up. No, they know more about themselves than I do, and that's how I've learned this. So I learned a lot from this woman too. She's got a horrible pain pattern, and I won't go into all the symptoms because there's too many to talk about. But look at her face. She's Korean, and she's really right on the money here. Her face is full to begin with, very full. And her nasolabial angle is acute. It should be 90 to 110 in this artificial world we've created for ourselves. So I want to help this woman, and I know I'm going to reopen the space on the left-hand side where she's had the bicuspid taken out. And I ultimately reopened a full bicuspid width on the left side and an extra bicuspid width on the right. I don't have pictures, but trust me when I say I had an extra bicuspid on the left-hand side and a full one for the tooth that was taken out. She was feeling much better, but she kept telling me, Dr. Heng, I want more and more and more and more and more. She was looking, to me, honestly, freaky. I was getting scared. Can you imagine Bill Heng getting scared doing this stuff? I was scared. I'm like, wait a minute, I don't want to do this anymore. And that's where she got to. And she was beautifully kind, brought us cookies, bought us fruit, whatever, nice thank you note all the time. Look at, she doesn't hardly show enough tooth here. See how little tooth she's showing? The teeth are disappearing under her upper lip. I hate this. And yet she wanted more tongue space and airway. That's why I thought of the title of this talk. I mean, she's beginning to look more like a grill, isn't she? And yet it's still not enough. And we parted company. She left my practice because I refused to continue to do this. I can't even believe this case. Crazy. Here's another person, essentially the same kind of thing. Joy, you know this person. At any rate, she's had ortho. She was retracted back. She hated it. And she's got sleep apnea. She wants more tongue space, and she doesn't want to do any surgery. Okay, great. Her jaws are back. You see that. Look at her nose-lip angle, her aesthetic line. The lips are really very far forward. And now the aesthetic line, the nasolabial angle is rather acute, much smaller than the quote ideal, but by our standards, then a pretty full face. And her airway is bigger than most. Anything over 110 square millimeters minimal cross section would be in a reduced chance for sleep apnea, but she has sleep apnea. The exact size of the airway does not matter. But if you were able to choose one, always get the biggest one. Notice what I've done for her ultimately. I've opened space behind the bicuspids, advanced the teeth, broadened it out like crazy. This is about as much as I could do. And her teeth don't fit all that well, to be honest with you. I want you to look carefully. They don't fit the way they should. And I'm proud to show you, I'm happy with this result. But she still probably has sleep apnea, and she would have had me do even more. She was still wanting more space. And I've gone from a 35.5 millimeter intermolar width to 38, plus the advancement. I've given her that extra tongue space. I hope she's done her myo. I think she even went to your course, Joy. She was in it. At any rate, and she's a lawyer, for God's sake. She's not a yeah. So let's go a little further to a small Asian woman. Now, all of us know that the NFL linemen that weigh 350 pounds, they're all having sleep apnea. None of them are going to be old men. They're all going to die early because of sleep apnea. But we don't think of small little Asian women who weigh 85 to 90 pounds having sleep apnea. And here she comes to me like this, and I showed this case in Nashville, but I'm going to show it finished, where she's at now. She'd achieved 3 millimeters of opening of the space here where her bicuspid has been taken out in, I think it was 3 years of treatment with an appliance that I will not mention. So she's got a laundry list of symptoms here going on. We ultimately opened up the space, did double jaw surgery to advance both jaws. I knew that she would not get out of the woods by me merely reopening extraction spaces, but this is what she said a year and a half ago. Out of the blue, she's sitting in a dental chair. Out of the blue, out of her mouth comes, I would do the surgery 10 times to feel the way I do today. So that's why here I am at age 99, or feel like it some days, still doing this thing. Because I like to get comments like this from people like that. So in her case, her airway at 178 square millimeters minimal cross section was bigger than many people in this room, and yet she still had problems with sleep apnea. The tonicity of her muscles was obviously collapsing. We can't depend on the size. There's so many different factors going on here that it's kind of crazy. But we got her 196, and she's happy. For her, that was enough. And she's got her broad smile back, and she's about as happy as she could be. A very, very, very happy patient. She emailed us, she had the surgery done, and she emailed the picture. She'd gone out for a walk 4 days post-surgery in St. Louis, where the surgeon is that I work with. And she wrote down here, put a bunch of rocks on the sidewalk that said, I breathe. And she thanked me and Dr. Movahead for this. Very appreciative woman. So, the next case we're going to look at here is like the basketball thing. There's a lot to learn. And Joy, this is the one I was telling you about last night. Now, Joy just showed a really interesting and cool case of Philip, my patient, that she did the tongue tie on. Here was a guy, everything done wrong. horrible apnea, teeth taken out, a little kid, all that. And we had to do double jaw surgery for him, but I couldn't reopen his extraction spaces because he had short roots. And his soft palate was way, way, way back. And we don't want to open up extraction spaces, A, when we have short roots and might lose teeth, and B, when the soft palate is really far back. When the soft palate is really far back, we want to maximize surgical advancement of the maxilla, which brings the soft palate forward. I don't want to push the teeth forward orthodontically. For every millimeter I push the upper teeth forward orthodontically, that's a millimeter that we don't bring the soft palate forward, the maxilla forward surgically. We want the soft palate forward. But the negative of not opening the spaces is we have this little garage that's too narrow and too small. And what Joy did essentially with that patient was help him learn to keep his tongue to the palate, even though he had a really scrunched up maxilla, proving that you can actually fit a square peg into a round hole. That's what Joy did for that patient, because she's good and that guy was motivated. Now, here we have essentially the same kind of a case. He's 27 years of age, had all these teeth taken out, was treated as an adult. He was not treated as a child. And as soon as the orthodontics was over, he started breathing and sleep issues, gasping, choking, racing heartbeat, stuff that Joy hears all the time, and Michael hears it all the time. I mean, this is the world we live in. And when you start asking your patients questions, like Michael suggested, you're going to find out that your practice is literally loaded with these people. They're everywhere. And then you're going to go like this, oh my God, how did I miss that? How did I miss that? And think of how many times I've felt that way in my life, all the time. How did I miss that? So what are you going to do? He's had 4 teeth taken out. Can I reopen spaces for this guy? Yeah. Produce a huge open bite, make him look like a horse with his teeth hanging out here. I could do it. And his airway is 28.5 square millimeters. That's an airway to die early with. That's not an airway that you're going to win the Boston Marathon. You probably can't even run 100 yards with an airway like that. Not good at all. So here's a case where I don't want to reopen the extraction spaces in the maxilla, because for every millimeter I advance the upper incisors, that's a millimeter that the soft palate will not come forward surgically. Very important to know that. When I do open in spaces in the maxilla, I'll usually do it in the second bicuspid position because I'll minimize the advancement of the upper teeth. And therefore, the surgeon can bring it forward more. So we decided not to do anything. That's what you call a squished drinking straw airway, right there. And I have next to the monitor for my cone beam x-ray, I have a drinking straw, and I pull it out. This is your airway. Everybody gets that. Then I also have a cocktail straw. Essentially, this is almost like 2 cocktail straws side by side. You can't survive with that. That's how far back his face is. And my point is, he got that way, and he knows this. He was a lifetime, his parents were from Poland, immigrants, didn't speak the language too well, and he had a lot of sickness. No one picked up on this. But still, people are not picking up on this. Just like Joy says she doesn't get referrals from pediatricians. They are the very people that should be seeing all of this literal epidemic that is far worse than the pandemic we're all wearing our facial mask to prevent. It's ridiculous. Far more people are dying from all these chronic diseases than are dying in this pandemic. But that's how you get the face back, by allowing horrible rest oral posture. If he'd have seen somebody like Joy Moeller, who helped him as a little bitty kid and get his lips together, teeth together, lips together, tongue to the palate, breathe through your nose, he would never have seen me or anyone else. Wouldn't have needed an orthodontist, wouldn't have needed a surgeon. So here we are to try to save the day for him. And we go with surgery to advance him maximally. This is as far as you can physically get it forward. We've got him to 121.5 square millimeters. Well, that's nice. How would it have been if we'd gotten it to 221? That would have been better yet. But you can only go so far with surgery. So this is a nice improvement, a great improvement, but not enough. So he comes back from surgery. He's doing well, but still not out of the woods. So I'm the one who's going to try to save the day. At no additional fee, I reopen the spaces. I'm now adding on, because I didn't see this coming, I'm opening 4 spaces for this guy on top of what I've already done for him. I've got him in a year and a half to get here, after the surgery, to get where he is. Notice that I've opened spaces. Notice that I have a lower retainer in. He's had a fixed lower expander in to expand the heck out of his lower arch. He's got a removable upper expander in. I'm non-surgically expanding his maxilla because I can do that, and I know everyone's into the whole surgically assisted expansion. That's fine if you like to do that. I got no problem with it. But I did my own maxilla, 7 millimeters of expansion without surgery. So if you want to do surgery, that's fine. And that it has a purpose and it has a place. But look at the big spaces we have for him now. And I referred him to an ENT for drug-induced sleep endoscopy to see what's going on here. Why does he still have apnea? Is it the soft palate that's falling back? Is it the tongue that's falling back? What else can we do for this guy? And he's had a tongue tie release, and he's married to a woman who does myofunctional therapy, and I'm assuming he's done all the right things. But in reality, I just talked to Joy last night, and I think I'm going to have to just say, you know what, you need to go to see Joy, because she's my savior. She takes care of these people, and I'm not joking. She's taken some of the worst train wreck patients I've ever seen in my life, ready to kill themselves. I have a woman who had pain for more than half of her life, and she'd worn braces 3 times. Came to me from San Diego and wanted to wear braces 4 times. She knew my braces were smarter. I said, no, my braces are dumb. I said, you don't have an orthodontic problem, you have a myofunctional problem. And she said, what problem? I said, myofunctional. Sent her to Joy. In 2 days, pain she'd had since she was 11 years old, when she was 23, pain was gone by doing Joy's exercises. She had a posterior lateral open bite of about 2 to 3 millimeters that she wanted me to close. In 6 months, it closed on its own. Now, do you think I like Joy for that? Yeah, it makes me look good. I don't have to be smart. I just have to know people I can refer to. What does that woman do today? This woman was a college grad. She went back to school. She became a speech and language pathologist. She has her own practice in Encinitas, California. And you know her. She's a sweetheart. She's getting married, did you know? She's engaged, yeah. That's a cool story, but it's all about myofunctional therapy. We got a lot of cards we have to play in this case yet. We're not out of the woods yet. And as he said, he's got lingual tonsils. There's a ton of other things. Possible hyoid suspension to bring the tongue forward. Maybe hypoglossal nerve stimulation. It's kind of crazy. Here's where he started. Here's where I am right now. And basically, I'd say, I've done everything I know to do, but we're still not out of the woods. See how far forward the surgeon got him? See how forward he is now once I've opened the spaces? It's really pretty crazy, isn't it? Now, it's not I don't want to make you feel like it's a downer. I'm happy to show you this, quote, failure, because I live in the real world, just the same world that you do. Always be suspicious of the person who has his cases are all successful. Do you really believe that? No. So sometimes we strike out, but we go to bat again, and that's what we're still trying to do. I'm not done with this case yet. So how do we end this? Is this where we're going to end up as a species? I don't know. Or is it here? Is this where we need to head? Now, I want to show you something. I'm not going to talk anymore. For the next 10 minutes, you're going to see a little video of where it starts and where it ends. And it's kind of, it really is going to get to you. Because it doesn't have to be this way. That's why you're here. And I'd love to see this group together with AOSH and with the AAPMD, collaborating. In numbers, we can make a difference. This Endeavor group trying to treat the really young kids, age 6 and under, that's the ones we should be treating. Recent survey in the Journal of Clinical Orthodontics basically says that most orthodontists the youngest they'll treat anybody is age 6. That ought to be the oldest they're treating, in reality. We ought to be treating the primary dentition. When do you call the fire department? When there are flames coming through the roof of the house, or do you, oh, I smell smoke. Call 911, call the fire department. So here, let's go and let's look. people who are in various stages of this. They're in your family, they're in your practice. And what are we doing about it? We got to do something better. You've been all great. Thank you very much. If you'd like more information, here's my...